colleague on board of Europa Uomo Europe, are trying to do repeatedly webinars about active surveillance in effect. But when we see what all is happening in the area of prostate cancer research and treatments and activity in general, we are exposed to many new things. And one thing that was really attractive, at least for me, which I'm coming from IT industry, was the use of say artificial intelligence inside the prostate cancer world. So in this period where we speak a lot of active artificial intelligence, because we have all the politicians speaking about that in a bad or good way, or bad way or good way, we thought it was interesting. Is it connected to active surveillance? Yes, we think so, because active surveillance is one of the most important type of treatment, and we think it can be expanded more and more. So the fact of having a support of artificial intelligence in the interpretation of imaging of this type of pathologies, it becomes a good idea, is a good important thing, and we think it can also help a lot of active surveillance, because it will help to the doctors, the medical specialists, to understand the cases where is not needed to go in treatments, but we can remain in strategy of treatments. So today we have, as we say before, the participation is from the fourth foundation, which started as Manolis was saying, started in Greece, in Crete, I think, from what I understand, but expanded as a foundation. And we have, in effect, apart from Manolis Trinakis, we have Daniele Regge from Turin, and I know that there is a spread of researchers working together all over Europe. So before giving the word to Manolis, I will say that today we want to go in the basic of this. The argument is not an easy argument; is quite complex, but we want to have between us people that are working in the board and the other in the European Association. We want to understand just the basic things, so that we can understand where and who can help us to further understand better in the deeper way. Today we want to speak about the platform and the artificial intelligence tool, which was will be the first part from Manolis Trinakis. I hope I pronounced it well, and then we will have a second part, which is what issues are clinicians confronted with in order to have an accurate diagnosis and treatment for prostate cancer. As I said before, the imaging is important and becomes strategic. The AI-based model are the third part, and in this case will be presented for the idea of prostate cancer management. So in short, we will try to get through these things. I introduced a little briefly Professor Trinakis, Manolis Trinakis, who was speaking before, is so what we understand as a very important curriculum vitae in these areas, in the Department of Computer Engineering, and in specific in the biomedicine, computation biomedicine laboratory. So we understand that you are in the middle between ITC, information technology, and biomedicine and medicine. So you are really important for us to understand what is going on. So I give you the speech, Manolis.
Okay, thank you, Cosimo. I will try to upload my presentation. Hold on a second. iPad, Hippocrates, show all. Here it is. Okay, so basically today and allow me, first of all, to say that I'm an academic here in one of the universities on Crete, but at the same time, I'm an affiliated researcher at Forth, which is a national R&D organization similar to CNR in Italy and Fraunhofer in Germany, etc., etc. And together with the other two esteemed colleagues of mine, Professor Reke and Professor Papanikolaou, who has a Greek origin but is actually leading an AI-related and focused group in Europa Foundation in Portugal. They will present themselves in more detail in a minute. We would like to present to you and discuss with you a European project called ProCancerAI, which is focusing in developing, as I will explain in a minute in more detail, artificial and intelligence-enabled technologies to assist optimal management of prostate cancer. And basically, I will try to give you the context very briefly in order to allow more detail, more time for my colleagues who will look into a deeper description of both the clinical aspects of the work of the project, as well as the AI, the artificial intelligence related part of our work. So basically, the European Commission back in 2019 opened the call in which they were asking to develop novel solutions based on data, large data spaces, large data repositories of medical images, which are to be used for the development of AI-enabled, as I said, technologies, and to study and provide, demonstrate the applicability of such tools in specific clinical domains, in the domain of cancer, for managing the most common forms of cancer, and thus increase the trust of both the clinical professionals, but also the patients and the wider society in the adoption and utilization of such tools and technologies. In the context of that call, 4 projects were selected, and ProCancerAI, the one that I have the opportunity to coordinate is ProCancerAI. Now, in the specific project, we focus, as the name says, we focus on the domain of prostate cancer, which I'm sure you know better than I do. It is a very important type of cancer. It is the second most frequent. Unfortunately, in men, it is still the third most lethal type of cancer. And when one, although Professor Daniele will elaborate in his presentation, as I said, deeper, the problems that clinical professionals face in the daily practice of optimal management of the disease, but there are specific unanswered questions that are related to overdiagnosis at times, over-treatment in other times, and in general, there is a lack of precision in the diagnostic process and management of the disease. And therefore, we argued that there is room, and we see potential in developing novel AI, artificial intelligence-enabled tools that go beyond current state of the art in order to provide more concrete and validated answers to some of those questions. So we compiled a very large, on the one hand, consortium that includes 13, the majority of the partners are clinical partners, so 13 centers of reference in prostate cancer throughout Europe. also recognize centers of excellence from the technical domain and the artificial intelligence domains, leaders in the domain of AI, such as I've already said, Nikos Papanikolaou, but also Harvard University from the United States. And we were given, we asked, and since we were selected as a winning project, we were given a budget, a total budget of close to 10 million euro to implement a very ambitious research program that I will very briefly present in a minute. The core management team includes the three speakers today, plus one of my colleagues, Kostas Marias, who was not able to be with us today. I coordinate, but Professor Rege has the very important responsibility to coordinate and lead as a clinical director the work of the project, and Nikos on the other side, the similar role, coordinating the work in the domain of artificial intelligence. Now, the vision is, as I said, the requirements were established by the call, and our vision was to respond to those requirements. First of all, to collect and harmonize and then capitalize a unique collection of prostate cancer multiparametric images worldwide, because we all understand that today artificial intelligence, and especially more modern approaches, deep learning, etc., approaches in the domain of artificial intelligence require significant amount of data. And our initial vision and ambition was to collect more than 17,000 cases and more than 1.5 million of medical images, which will then be utilized in the context of our work to develop clinical tools, AI-based solutions, etc., that I will very briefly in the subsequent slide explain the domain of application of those tools. But once those tools are to be developed, our additional objective is in order to increase the trust in AI-enabled tools, to actually go through a thorough clinical validation in the setting of these 13 reference centers in Europe. Again, Daniele will elaborate, but in selecting the questions, the problems, the so-called, in our language, we call them use cases, but basically the clinical questions that we decided to focus span the whole continuum of management of the disease, which starts from, let's say, highly accurate detection, the presence or absence of the disease, simply based on imaging and related clinical data. But there are subsequent questions and urgent clinical requirements also related to characterization of the aggressiveness of the disease, or even develop AI-based tools to support optimal patient stratification, as Cosimo said, for inclusion in active surveillance programs. And as I said, Daniele will elaborate on this in a minute. Now, we collect significant, we said our ambition is to be the highest data repository of prostate-related multiparametric imaging data in the world. Of course, we understand that there are ethical and there are legal issues, because we are dealing with very sensitive patient data. And we made sure that we taken provisions and devoted significant work in making sure that we developed a very thorough and detailed legal and ethical framework to guarantee the security and anonymization of personal data in line with all the provisions of GDPR. So we've taken a lot of devoted, as I said, a lot of effort to establish detailed legal and ethical framework, to perform a data protection and assessment of the security requirements, to develop legally bound data ownership and sharing agreements, and to perform a deep assessment of the risk for re-identification or potential for re-identification of patients based on the collected data, and also to develop the legal framework for the exchange and the collection of these data, everything in line with the provisions of GDPR. And I would only like to say that based on this analysis, we develop a novel process to fully anonymize the data that was, when presented in the relevant workshops, very well accepted and received by the European Commission, and it's been thereafter adopted by other related projects who also seek to achieve a high degree of security in the context of sharing and utilizing data. So currently, the project has achieved most of its initial ambitious objectives with respect to collection of data. We have close to 7 million images, individual images, and more than 20,000 data points for the development of the models that we will be speaking in a minute, coming from today close to more than 11,000 patients, but the prospective recruitment and collection of patient cases still continues, and it will continue for another year. So there is in front of us the opportunity to truly achieve a unique collection of high quality data, which is then, as I said, to be used for developing the models. That data, and I'm not going, of course, into the details, has gone through a very thorough process of preparation, assuring the quality of the data, so that the models, the AI models that are being developed are truly representative of the world and the real world. And we are currently in the process of model development, and we have in front of us a significant period of activity, which, as I said earlier on, relates to applying those models in the context of clinical practice with the objective to validate their correctness and proper functioning before models, AI-enabled tools and models are taken into production, which is, of course, a very complex process, and it's not within the scope of the project because that would demand regulatory approval of the models, etc., which is a longer period in terms of time in order to achieve the approval of an AI-based model, either by the FDA or EMA for introduction of such models into routine clinical practice, but that is the ultimate objective of the project. So basically, and I will stop at this point, giving the floor to my colleagues, we are working hard, having collected and generated a unique data resource, and as we will describe in the subsequent presentations, very novel solutions with respect to AI-enabled and fueled models to answer a range of clinical questions that are very important. We believe that the project is about to deliver some significant results once some of these models are actually clinically validated within the next 12 to 14 months that we have in front of us. So with that, I would like to thank you and give the floor to Daniele to continue the presentation of the clinical rationale and related activities of the project. Thank you.
Okay, do you hear me? Just give me a second. I'm kind of...
Yes, we can hear you nicely, Daniele.
I need to turn on also my video and things like that. Okay, so
can you make it presentation mode?
Yeah, do you see my slides now? Do you
yes,
see?
Yeah, that's fine. Yes.
Okay. Okay, I can.
You are from Candiolo Research Center, right?
Yes, right. So I'm a researcher in Candiolo, and I was a professor at the University of Torino. Now, and as Manoli said, I coordinate all clinical centers, which are 13, and they are spread out through Europe. Okay, so we have centers in Spain, France, Greece, Turkey, Lithuania, and so on. So so let's start, but let's start from the beginning of this data. I just want to give you an idea, still remind you how impressive they are, because basically a lot of 200,000 patients or more develop prostate cancer each year. The incidence is growing, and as you can see, a lifetime risk is very high. In 1 in 8 men will develop prostate cancer. It's of course important what kind of cancer we develop, because if it's localized prostate cancer, indolent prostate cancer, you have a very long survival time. Some of these cancers you don't even need to treat. If you have advanced cancer, it's a completely different disease. So you have to be very aggressive at diagnosis by removing or anyhow treating the prostate with radiotherapy, and then you have to look for follow-up and look if they are developing metastases, and if you have metastases, you have to try to stop the disease with some kind of systemic therapy. So it's a disease for many old age men, okay? So a risk factor is age, and as you can see, only a very few men actually die from cancer. Okay, so there are lots of diagnoses, but very few die from cancer. This is because overall, the disease does not have the mortality of other types of cancer, like, for example, lung cancer or pancreatic cancer, which very frequently bring to death. This is a different disease. How do we diagnose prostate cancer? Now we have this MRI, which is fairly new, and we actually for the first time ever are able to detect prostate cancer, to see prostate cancer in patients. We could not do this with ultrasound. Ultrasound is not sufficiently high resolution and contrast to detect prostate cancer, and you get confusing images. Sometimes you get infection and prostate cancer, they look alike. But MRI is different. MRI is really very high sensitivity and specificity. Prostate cancer shows up like a dark area on T2. We call multiparametric because we have different sequences, and we have T2-8, which is anatomy, and you can see here the central zone is the darker area in the center, and then you can see the peripheral zone. I hope you see my arrow, and in the posterior and the two lateral. So the tumor is dark, And then we can perform diffusion imaging, and again, and with some simple processing, we can get some maps, which we call ADC maps. And we see a darker spot here on these ADC maps. This is cancer. And we can also add one more sequence that is a dynamic with contrast, okay? And that is the tumor shows up as a hyper-enhancing tumor, which is brighter spot with respect to the rest of the gland. When you have this, you have no doubts. Of course, there are not all cases are easy, and for this reason, we have a classification which we call PRADS, and PRADS is basically the probability of having prostate cancer on the MRI images. Okay, so if you have PRADS1, the gland is basically normal, so you don't have cancer usually. It's very, very low probability. If you have, on the other side, you have PRADS5, you will have a very high probability. This is based on morphological and functional signs in the MRI scan. Okay, so the radiologist has to interpret, and then he gives a score. There are, of course, cases where we are not sure. Okay, so we don't have 100% accuracy, unfortunately, and we'll see. And this is where artificial intelligence comes in. The artificial intelligence, as we shall see, will help the radiologist to pinpoint the cancer, and especially in those doubtful cases. Of course, there are other indications, but this is the basic indication to detect cancer and to try also, we shall see, to give a score to cancer according to the aggressiveness, whether it's indolent or aggressive, because that's very important. So one other thing about MRI is that we can direct, now we can perform targeted biopsy. Some patients with prostate cancer, some of you will remember, performing 12 or even 16, at some point in time, even more than 20 biopsies, because you used to do some kind of a concentrated biopsy, you had to biopsy the whole. Now with prostate, with a prostate MRI, we can, and with fusion, with ultrasound, or directly in the prostate scanner, we can perform direct MRI. We can hit and target the tumor right directly. So it's about 3 or 4 years that even the guidelines for urology guidelines have changed dramatically. Okay, now since 2020, it's clear we have to perform MRI before anything else if you have suspicion of prostate cancer. You can have suspicion by PSA or by urologist visiting you, and in this case you have to perform. And you also you have to perform biopsy if you had prior negative biopsy, which is negative, and you have suspicion. Again, you should also perform MRI before a second biopsy. Okay, where still we are not using MRI is for screening. But we are working on this, but for the moment it's not in the guidelines. Okay, and you can see here that also we need to adhere to this PRAD score, and both the radiologist and urologist have to comply by this PRAD score. Okay, so, but that said, of course, there are some issues with MRI. As I said before, MRI is not perfect. You might have false negatives. That means that you don't see cancer. If cancer is small, or there are certain types of cancer you cannot see. You can have false positives, and not all of these are negative patients. There are also patients with not clinically significant prostate cancer, so you can have overdiagnosis. That means that will be patients that perform biopsy, for example, because they have a false positive at MRI. You have lots of differences in performance that is related to the experience of the radiologist. The examination time is long because we still have to perform a lot of sequences. Probably AI could help us somehow reduce both the examination time by doing some very highly sophisticated post-processing. We won't talk about this, but this is already feasible. Or by somehow reducing the number of sequences. Once we get, with the support of AI, we could get better, better information or extract more information from the MRI, and then we don't need all this scanning time. Okay, well, we still don't know why some patients develop prostate cancer and why recurrence, and why some others don't. So there is a lack of predictivity in general. We cannot predict this with our eyes, but we need something else. Probably in the future we will be able, based on the characteristics of the tumor at MRI. So this is the slide the flow chart that you've seen before, that Manolis has showed you. And so these are use cases. I will go through them. And the first one is on use case on detection. So MRI, artificial intelligence, we are trying to understand if with artificial intelligence, we can improve the detection of the tumor, okay? That's one first step. And these are examples of how, for example, tumor is detected by MRI. This is the tumor, and you can see this color-coded map, and you can see how, your eyes can focus directly on the suspicious points that are, in this case, two small tumors, one small and one large tumor of the prostate MRI. So this is the kind of images that you will probably get when you have the processing with artificial intelligence. And but we can also use, for example, artificial intelligence. Any kind of output of artificial intelligence has to be mediated by the human, the radiologist in this case. So there has to be some kind of mediation. We cannot trust AI blindly, okay? So we could have different situations. For example, we could have MRI. If MRI is positive, well, maybe we can just check, the radiologist can check more carefully, just a fast check by one radiologist, but we are not sure. We are, let's say, in the middle, what we said are PIRADS 3, then this is indeterminate. Maybe in this case, we can follow up with interpretation by two radiologists. And if we have negative, maybe then we don't even need a radiologist. Maybe the MRI can be enough. This is what we call rule out. Of course, there's some resistance on this, and we have to have very high certainty about being negative. The exam must be sure, we must be sure that it is negative, and so we have to have what we say a high negative predictive value. In that case, probably we don't even need a radiologist. So just to give you an idea that we really need to anyhow to interact with AI. Okay, for example, one idea is about detection, that if we have AI, we can shorten, I said that before, the MRI example. For example, we could use only two sequences instead of using three, and the scanning time can be reduced dramatically, even to 10 or less than 10 minutes nowadays. And this is a study, it's a randomized study that we did comparing the two, and you see there are still slight advantage of multiparametric with respect to biparametric, but this can be flattened out by biparametric MRI. So maybe what we are looking forward is to shorten a lot the examination time, so we can also maybe use this new biparametric for screening. But this is, as I said, work in progress. Okay, but we talk about screening. You can see here that for sure screening is in the DNA of MRI. We are waiting for results. We are really but simulations, they are saying that the quality of life and the survival will improve extremely if we introduce MRI in our screening with respect to, for example, PSA-based screening and so on. So this will be, next few years will be about this. So the other thing is that we need to, this is use case number 2, we need to characterize cancer. So we need to distinguish high risk, medium risk from low risk. Why? Because low risk doesn't need operation. You know this very well. Low risk can go into surveillance, okay? I know this is something that you are very interested in. And so, if, for example, if for example, MRI was able to evaluate aggressiveness, by the way, the radiologist eye cannot evaluate aggressiveness. So you really need some quantitative artificial intelligence measure. We could, for example, divide patients from those that need to perform immediate biopsy because they have suspicion of a highly aggressive tumor, and maybe this could go on much higher on the waiting list for surgery, okay, because they are high risk, so we can also do that. And maybe in a low aggressive, or maybe there is a case for no biopsy, or indeed also for a delay, at least in biopsy, because these are less urgent cases. Okay, so let's see, or maybe we can even map tumor heterogeneity. Tumors, they are not all the same. They have some areas where, for example, the red area in this case, in the study, where tumor is very aggressive. There are some low-risk areas where there's tumor, but it's less aggressive. And we can also direct the tumor, the needle, for example, in the higher aggressiveness part, okay, which would be very important. As you know, biopsy, the risk of biopsy is to underestimate the aggressiveness of tumor. I'm talking about tissue biopsy, not a virtual biopsy, which we are working on, and it's about aggressiveness, but in that case, we should have the right Gleason score. Okay, so this is what happens with a surveillance. We could actually monitor the patients and see how these parameters change, and if they change in a certain way, then we have to have a warning. We have a warning, and for example, this is a very simple paper. We just consider one parameter, the ADC maps, and in this case, there's a warning because the ADC map dropped, but we could probably get a much more information from artificial intelligence. Let's go on because I am just 3 or 4 more slides just to tell you that there are other. So there's another important use case, which is use case number 8, and that's about selecting patients for active surveillance. We plan to do this with MRI, and we also with use case 7, we also try to predict what, for example, the side effects that will be able that can be developed by treatment. Okay, but this is a more ambitious, let's say, exploratory endpoint. The most important thing is to be able to detect which patients, not only follow-up patients, but also to be able to detect patients that will need to don't need surgery. They need just follow-up, okay? And as you might know, surveillance really works because if you don't have a very high risk, which means Gleason score 3+3 or 3+4, these people, they have the same survival if they had surgery, radiotherapy, or active monitoring. So I think that we should really push more into active monitoring, and I think that the MRI will be able to help a lot. And finally, there is a more holistic use case, which is use case number 9, and this is about predicting which is the best treatment with the lowest side effect and toxicity. This is something that we added on to our project later on, but we think it would really be able. It's some kind of a clinical decision support system to be able to understand which is the best treatment in each individual patient. So there are some also some the last 2 slides to just talk about advanced disease a little bit. We have the ambitions to predict which patients will have a higher probability of developing metastasis and which patients will have a high probability to develop a recurrence after surgery and after radiotherapy. So this simply based on MRI, so no other parameters. So we think that maybe there are some features of MRI that can tell us before even we start treatment, that diagnoses whether these patients have a high risk of developing metastasis. Because if we know which ones are the good ones and which ones are the bad ones, we could probably prevent the development of metastasis, doing, for example, performing a more aggressive surgery, or maybe performing some kind of neoadjuvant treatment. That means treatment before we perform any kind of surgery, or we perform adjuvant treatment, or so on. And so this is something that we are trying to understand if we can somehow give some indications on this. So with that said, I'm finished. I'm, of course, available for questions later on when we are over with the lectures.
Thank you very much, Daniele, for this wonderful presentation. Really appreciated all the basic indication that you gave, which explain a lot about this. And now I think we give the speech to Papa Nicolaou, which I understand is a leader of the computational clinical imaging, so it certainly is giving us another important view. Nicolaus, you can start. Thank you. We see your slides in effect.
Nikos, we cannot hear you.
Okay, apologies for that. Thank you so much for the introduction. Just to set the scene, it appears that in the last 5 to 8 years, there is a twin explosion, an increase in terms of AI research activities, as shown by the vast increase in the number of published studies on the right side, that is also coupled with a substantial amount of financial investments made in companies that are working in such a field. However, it seems that such investments haven't matured yet, since there is a phenomenon that is called the AI chasm, where despite the fact that we are bombarded almost on a daily basis in the news about the AI disruption of several activities in life, including healthcare, only a handful of such AI models are being used in the clinical environment today. That is mostly explained in the basis of little high-quality, convincing evidence regarding potential improvements that AI can bring for the patients, the caregivers, and the health care systems. Now, most of the AI success stories are based on 3 important pillars, which are primarily the availability of high quantity and quality data that are diverse enough to simulate real-world data, and in addition, access to affordable computational power and improvements in AI algorithms. Now, the idea of ProCancer Eye, as it was already mentioned by Manolis and Daniele, is to form the largest data repository worldwide, hosting prostate cancer relevant data, mostly multiparametric MRI, and harness this data in order to train and validate several dozens of AI models in a form of a marketplace where radiologists, urologists, radiation oncologists, and patients may select and used by uploading imaging data. For the latter task, 9 AI developer teams have been working hard during the last year to make use of the data and train such models. In ProCancer Eye, we are implementing a so-called holistic validation pathway that includes several steps. At the moment, we are almost halfway finishing the prospective validation of our models. Now, I will briefly show you the most recent results that we have obtained, just to understand where we are at the moment, starting with use case 1, the detection model. The results we obtained so far are very promising, with performance exceeding 80%, and which possibly can be used to augment, especially when inexperienced radiologists are in place and they have some difficulties to detect accurately prostate cancer lesions. Moving to a more interesting area, like Daniela said before, where radiologists visually can only add very little, that area is the disease aggressiveness evaluation in use case 2. Here we see that the results are very positive, confirming high performance around 85%, even in the prospective patients so far. We are making use of dedicated methods related to the so-called explainability need, where we are providing the inner mechanics of our models in an attempt to explain why and how a model makes one or the other prediction. This is an important prerequisite in order to increase trustworthiness and therefore utilization of our models by the end users. Some of our use cases, like the one for metastatic disease, are severely underrepresented in our dataset, and that's why such models are still works in progress. However, initial results are quite encouraging, and they give us the chance to continue recruiting more patients that fall under these categories. Now, use case 4 is all about biological validation of our models. And for that reason, one of the partners, ourselves here in Lisbon, Sampalimau Foundation, is currently running a prospective study with patients that are undergoing or scheduled to receive radical prostatectomy. And before surgery, a personalized hollow mold is generated by using the patient's MRI data on a 3D printer, where after surgery, the surgical specimen is squeezed inside this hollow model and cut it into slices that are exactly at the same geometry as the MRI. And here we can see the corresponding three-dimensional personalized molds. The reason of doing that is because we want to perform the so-called radiologic pathologic correlation, putting the MRI at the top of the digital slides to understand at the tissue level the AI features that our models are using to make predictions. Now, use case 5 is all about predicting the risk of biochemical recurrence after radical prostatectomy or radiation therapy in use case 6. However, still, we are recruiting patients. We don't have yet credible results that could lead us believing that this can be used in the clinical practice, although the initial results are rather encouraging. Now, use case 7 is all about toxicity and quality of life, where again, the results are still not good enough to be used in the clinics, and we are still trying to improve them by recruiting additional patients. Finally, use case 8 is all about patient selection for active surveillance, where we are trying to predict premature departures of the active surveillance program during the first year of enrollment. Now, let me show you 3 representative examples, starting with the AI detection model, where here the different colors are representing the different probabilities of hosting aggressive disease. The model in this example correctly localized the small aggressive cancer in the right peripheral zone. Now, Okay, in this example, we have a patient with a rather large, nasty-looking lesion, as you see by the arrows, where the model predicted this case as a low aggressiveness and surprisingly confirmed to be correct after biopsy. It was a Gleason 3+3 lesion. In another similar lesion to the previous patient, this time the model predicts aggressive disease, and again, biopsy shows that this is a Gleason 4+3, which was a correct assessment. Of course, there are some false positives and false negative results, but those are the minority so far. So to conclude, we have very positive results in the field of detection and characterization of prostate cancer, disease aggressiveness namely, while we have encouraging results for all the other clinical use cases. It appears that there is still learning capacity for most of our models, and therefore we are actively seeking for new data to complement the existing repository and further improve our AI models. And with that, I want to thank you so much and preserve some time to answer to potential questions that you may have.
Thank you very much, all of you. From my point of view, the presentation was very good because it gave us a basic idea, a very clear idea. So for me, it's difficult to have questions, to be honest, because I've seen a very good something that I was expecting. This is what I was expecting, so I'm satisfied with this. But I think between all the people attending, there could be some questions. Anya is checking on the mail on the chat to see if there are questions. But if you want to raise your hand, we can give you the speech. So you don't have questions, probably?
No, there are no questions in the chat. Yes, there's one coming in.
Okay.
Let me see. How can the Baltic countries get involved in data collection? It's coming from Eric from Latvia.
Daniele, would you like to take up the question?
Yeah, well, we have a very active member in Lithuania, so we already have a pretty good representation of cases coming from Lithuania. I want to stress, it is a very good question, because I want to stress the fact that we need really to have data from everywhere in the world, ideally everywhere in the world, if we want to have develop a software tool that is generalizable, because it's not so obvious that software that has been developed in Europe, for example, will work in the USA or in Africa, where probably there is a different prevalence of benign hypertrophy, and where there are higher prevalence of cancer in certain groups of patients, of people, like, for example, Black people, they have higher percentage. So, I mean, so that is the reason why we have been trying as much as possible, at least in Europe, to collect data from everywhere, even from the Baltic countries.
Yeah, there is a follow-up question. If I see Daniele, what is his name? Well, it's NCI, it's the National Cancer Institute in Lithuania. But I would simply like to follow that if there is interest from, and if you know a specific center that would be interested to link with us and act as data producer, and we would be happy to discuss. We currently, just to follow what Daniele says, we've had expressed interest from Australia following relevant presentations about the the vision and the current results of the projects, and we are discussing with a number of other potential donors, data donors, And the reason for their interest, although the project does not have the financial capability to support such activities, is the fact that they said they would like to see their populations from Australia or other parts of the world that we are discussing to be included in the population on which the models are trained. So if and when, not if, when the models are actually reaching clinical application and they're adopted for clinical practice, the relevant population has been represented on the data on which the models have been trained on. So we would be happy to discuss with potential centers, countries, regarding the rules and the conditions that need to be applied to join and collaborate for data generation and delivery. Nikos, would you like to add anything?
Well, I would, since there are not so many questions, I would like to pose the question myself to everyone here in the audience. One of the, let's say, wrongdoings so far in the majority of AI development projects is the fact that we are not inviting the end users from the very first moment when designing such projects. And patient associations are clearly underrepresented in this type of multidisciplinary teams. So I wanted to get your feedback and your feeling about that, whether you would be interested to participate and to provide your valuable input regarding, for example, how relevant may be the models that we are designing. We are not patients ourselves, so we can only estimate what would be the needs of patients, right? So I would like to get your echo on that topic.
Well, allow me. Thank you, Nikolaos. Thank you, Daniel. And thank you, Manolis, for the excellent presentation of today. But I would like to reply to your question, Nikolaos, about the subject. For sure, as a patient organization, sometimes we feel a little bit disappointed that we are not invited. So definitely, I would say it's a very, very important point that on top of the rest of the participants, the patient organizations should have a word and should work. And at the end of the day, our presence and our duty is to try to help patients, all of us. So definitely Europa Uomo, and I'm talking on behalf of the board of Europa Uomo as the treasurer of Europa Uomo, it will be our honor to be invited to see how we can help and how we can support. Thank you. Thank you very much, everybody. It was a lovely, lovely presentation. I personally enjoyed it. Having all these informations today, maybe this is the 8th or 9th active surveillance presentation that Cosimo and Tanya have organized. But I will say today, I have learned quite a lot of new things and very much appreciating your help, your support, and your cooperation. Thank you.
Thank you. Thank you very much. So if I understand, Mr. Vanezos, you would be, even today, be willing and interested to join, let's say, an advisory committee as Europa Uomo, not individually. Although, as I said earlier on, unfortunately, we do not have budget to fund the relevant activities, but we could fund, of course, potential traveling expenses if someone would have to join the meeting of the project. We have, as I said earlier on, another 15 months ahead of us. We expect some significant scientific and technical work and validation. So I would see still personally, I see some important contributions from the patient side regarding the way and the processes and the methods that we will employ to clinically validate the number of AI technologies that Nikos explained very nicely that are coming out of the project. So if that's the case, we would be happy to discuss at the management board and potentially invite Europa Uomo to join.
As I said, I represent the board, but definitely, as you certainly know, I have to get the board's approval, as we do always, whenever we have to join a certain project and a certain direction. So if you are interested that the Europa Uomo as a patient organization to be part of a small part of the big project for the rest of the time, please send us an invitation. Anya, that she is with us today, and she's the executive secretary of our organization. She could add it to our next board's meeting point of discussion.
Okay, Cosimo is part of our advisory board today, and we are lucky to have him, very cooperative in assisting us in reaching out to the patient world. But potentially we will discuss in our own management board potential additional experts from representatives from the patient world in the forthcoming activities, which I think are more tuned and more to represent and the patients and have the patient voice in relation to concrete results that we are now about to deliver.
Just a quick question, Cosimo, are you participating as Europa Uomo Italy or as Europa Uomo Europe?
You're muted, Cosimo.
Sorry, I participated as Italy, and as I said, my purpose was to understand, to create a link. So the fact that today we have been able to see a synergy between what we do is for me a good opportunity to say that this should be discussed in the Europa Uomo board, Europe board, because the impression and what we see, what we have seen and what we see today, I think is useful. Also because as we are more and more in the advisory board in, let's say, local prostate center in all Europe, in all countries. For instance, for us, it could be we could put forward the fact of giving the proposal to these big centers to exchange data information with Fort consortium, because obviously the efficiency of this system is also related to the quantity of data they can get from imaging around the world, in specifically Europe. So I think, in short, thank you very much to all, and I think the objective of creating a link is going to start. So we have, I hope we have done something useful for the attendees and for the future of the patients, let's say. Okay.
Dear Cosimo,
Yes.
I would like to make a reaction to us. What the question was to us, because I would like to say, of course, thank you so much for very nice representation for everyone. And according to our Lithuanian National Cancer Institute, because he is really very active in cancer, prostate cancer, probably we are very close, like patient association. We make agreement with this institute. We are working very close. And then I would like to recommend to all countries, patient associations to be as possible closer to those institutes, because they know how to explain to the patients how to choose the screening for everyone. Which one is works better for different kind of disease of prostate cancer? In this case, we are so happy to be good, very close partners with our Lithuanian National Cancer Institute, and we of course thank you so much for nice presentation once again. It was very interesting, and I heard also very nice, interesting news about the prostate cancer this time. Thank you.
Thank you.
So thank you. I think if there are other questions, or do you see other questions, Anya? No. No. Okay. So we can close, and we hope this is not a complete presentation, but it's just the beginning of a discussion on deepening information about this important task.
Thank you very much for giving us the opportunity.
We would be very happy to host you also physically sometime in the near future and organize a physical dissemination event, possibly in Lisbon, if you like the idea.
Well, I believe that we are having the EMUC 24 in Lisbon this year. So maybe, Nikolaos, maybe it is a golden opportunity that we meet.
Absolutely.
Could you send us the details of when the event is taking place, so that we then, Cosimo, can you take the responsibility to pass us the information on our email, so that we then follow on the organization of a relevant meeting?
Yes.
It would be, for us, it would be very good. It would be very good to have a number of representatives from your side to actually physically demonstrate how far we've gone and what are the plans in the remaining period of the time. Thank you very much again. Thank you.
Thank you very much. Bye.
Bye-bye. Bye-bye.
Bye-bye. Bye-bye.
Bye-bye.